All right, we got some folks coming in. Welcome, everybody. We're going to get started here in just a second. We're so glad that you're joining us today. Hello to Simran in Toronto. Wow, pretty far away. We're going to give folks about 60 more seconds to trickle in so that we can have everyone here. We're delighted to be here with you today for a really important discussion on cardiometabolic health. All right. Are you good with me getting started, Marie?
Yes, ma'am.
Perfect. Well, welcome everybody. We are so glad that you're able to join us this afternoon. I'm Dr. Joy Baker. I'm a practicing OB-GYN in small town Georgia, and I am delighted to be back with you again this week to host a fireside chat discussion with a dear friend and colleague, Dr. Nicole Plenty. Dr. Plenty is a board certified maternal fetal medicine specialist and the founding director of Wellstar Health System's maternal fetal medicine division. She is dedicated to caring for women with high risk pregnancies. She has expertise in managing complex maternal and fetal conditions, and she's passionate about improving outcomes. She emphasizes evidence based care, early intervention, and patient centered communication. Dr. Plenty is also committed to advancing maternal health equity and empowering patients and families with the knowledge and support they need throughout pregnancy and beyond. Welcome, Dr. Plenty.
Thank you so much for having me, Dr. Baker. I am just in awe of you and everything you do to try to help reach people and educate. So I'm very honored to be on your platform today.
Well, we are absolutely blessed to have you. I can tell you, ladies and gentlemen, that I work with Dr. Plenty quite a lot, and she is absolutely fantastic. So we were over the moon when she agreed to take this hour with us to talk about cardiometabolic health before, during, and after pregnancy. So, Dr. Plenty, in your opinion, why is this such an important conversation for us to be having right now?
I think, when we talk about cardio and metabolic health, it's basically how those metabolic conditions affect your heart disease or your heart condition. So when we talk about obesity, insulin resistance, and how that can actually have a big influence on your heart and your heart function. And so it's important to talk about it before pregnancy because obviously the things that go on with your body before pregnancy really impact what happens during the pregnancy. But then the pregnancy sort of compounds everything that will happen to your body. It makes your heart work harder. It makes your kidneys work harder. It makes your pancreas work harder. And then that then has a downstream effect on your overall health later on. So I think it's important to have these conversations at pretty much every stage of life so that we can take a step back and say, okay, what is my health status right now? And what do I need to work on getting to get my health status better?
I totally agree. And when we think about pregnancy and like planning for pregnancy, I think it's so important to have a good idea about what our cardiac status or our cardiometabolic health is prior to pregnancy so that we don't unknowingly compound issues during the pregnancy. So I think that's a huge deal. Um, Pregnancy is often described as the stress test of the heart because it does make the heart work a lot harder. So, what does that mean clinically and even long term for folks who become pregnant that may have issues with their cardiometabolic health?
So the stress test is that's such a polite way to say it because it is like 10,000 stressors, right? It really does make everything work harder. Your blood volume doubles by 6 weeks of pregnancy and just continues to gradually increase. So it makes your kidneys work at least twice as hard, which is why when we look at those values of what your kidney function is like, that GFR, your glomerular filtration rate, which is how much blood your kidneys are actually filtering, should be doubled in pregnancy, which then cuts other values in half because it's filtering at twice the speed. it stresses your heart even more. So people that did not have heart disease before, or they didn't think they did, or they may have been like, oh, I just have a little bit of hypertension. In pregnancy, all of a sudden you have uncontrolled hypertension because your heart is working twice as hard. Your vessels are more constricted. So it really does, hit your body like a Mack truck. So if you're not as healthy as you need to be, pregnancy really is the thing that's going to test you to the limit to see like how much your body can truly handle. And so that's why the preconception part is extremely important. And people get upset sometimes when they come in the office for a preconception consultation for, IVF, or even people that are just more in tune with their bodies that want to make sure they're healthy before they go into the pregnancy. And I'll say, wait a minute, let's wait 3 months. Let's put you on some pregnancy safe medications to get your blood pressure down. And let's wait a couple months before you get pregnant. Or I'll say, hey, let's lose 10 pounds because we know that weight loss as little as 10 pounds will help with ovulation. Some people get disappointed. I'm like, no, we just want to make sure that you're as healthy as you possibly can be, because if we get you very well controlled, then we know that you'll get through the pregnancy way safer than if you were uncontrolled.
Yeah, and I like to tell my patients like the goal of becoming pregnant and wanting to have a baby and to expand your family is to actually be able to do all the things that you dreamed of, right? To run and play with your baby, to snuggle and love on your baby. But when you have significant health risks going into the pregnancy, sometimes now we're concerned about, are you even going to be able to make it through this pregnancy safely? What about after delivery? Because we know that those who have poorer cardio metabolic health may be at risk for postpartum cardiomyopathy, where the heart just sort of fails as a pump after you deliver your baby.
Yeah.
And we know that, particularly for Black women, cardiovascular disease is going to be a leading cause of death for us. So I think it is important to have those preconception conversations. What are the key cardiometabolic risk factors that you like to look for when these patients are coming in to see you for a preconception visit?
So I know people don't like to talk about weight, but it's a big risk factor. It's a huge
Mhm.
risk factor. Weight leads to a lot of downstream complications, and honestly is associated with a lot of medical problems. If people weren't obese, then they may not have as many medical problems. They may not have high cholesterol. They may not have uncontrolled hypertension. They may not have uncontrolled diabetes. So for me, obesity does play a big role in their metabolic health, which obviously lends to their cardiovascular health. So we talk about, what do we need to do? Are we at a healthy weight? And listen, y'all, I'm not skinny. Okay. I'm not skinny, and I was not skinny when I had my baby. So I always tell people we're in this together. This is not trying to get you to a perfect weight, right? But it's trying to get you to a weight that is going to optimize your health if you have other health conditions. So, if you're obese and you have diabetes, I know that if you lose a little bit of weight, that's going to help with your glycemic control. It's going to help with your finger sticks and how well controlled your finger sticks are. And there's a lot of things that we can do before pregnancy that we can't do during the pregnancy. And then after the pregnancy, those things, continue to stay with you, right? It's harder to get weight off after the pregnancy than it is to lose weight and decrease your risk before the pregnancy and then continue on your weight loss journey afterwards. So obesity is a very big risk factor. Diabetes is the bigger one, right? So if you have diabetes and your hemoglobin A1C, which is that number that tells us what your average blood sugar is over the past 3 months, if that number isn't at goal, then that can have a lot of implications on not only your personal health, but on your baby's personal health. So people that have an elevated hemoglobin A1C, meaning you're not a controlled diabetic, that puts you at risk for having a baby with heart defects, put you at risk for having a baby with open neural tube defects or spina bifida. Can also put you at risk for a baby having being big. You can have complications during delivery, like a shoulder dystocia or the shoulder getting stuck, which means that you may need some intervention to get the baby delivered, or even a C-section at the time of delivery. And we also know that uncontrolled diabetes can be associated with a higher risk of having a stillbirth as well in pregnancy. So absolutely, that is the biggest metabolic issue is diabetes, and that's pretty much the most common reason I tell people to wait to not get pregnant. I'll say, wait, let's wait until your hemoglobin A1C is at goal, and of course, we want to make sure that your A1C is somewhere around the goal is of course 6%. 7% is acceptable, but 6% is where we want you. And A1C that's at 8% is where we get the higher association with babies have congenital heart defects, spinal cord defects, which can lend to brain defects and brain abnormalities. And nobody gets pregnant to have a baby that may knowingly have an increased risk of complications, right? So we want to do everything we can to get that number under control. And then the third thing in terms of cardiometabolic issues will be hypertension and uncontrolled hypertension. We know that if you have controlled blood pressure that are and you're on pregnancy safe medications, it's going to be much easier to get you through the pregnancy. Now, it doesn't decrease your risk 100% of getting hypertensive disorders of pregnancy because people with that get preeclampsia, which is high blood pressure and protein in your urine, obviously can have no risk factors or may have hypertension. We know that people that have hypertension have a sevenfold increased risk of complications, including a growth restricted baby. Growth restricted babies have an increased risk of stillbirth. That's why they have to be watched much closer in pregnancy. They can also have an increased risk. They also have that sevenfold increased risk of getting preeclampsia, which is what I said, high blood pressure and protein in your urine. So those are the main cardiometabolic risk factors that I definitely address to make sure people are safe during pregnancy. And it's also the main things I follow after pregnancy to make sure that people are controlled even after. We want to make sure that after your pregnancy, we don't just sort of wash our hands and walk away. We want to make sure your blood pressure is still controlled, right? We may need to continue to follow you to make sure that you're not developing cardiomyopathy or heart disease as a result of the impact of pregnancy. We want to make sure that you're followed and transitioned and you're seeing an endocrinologist to make sure that your diabetes is controlled. And then, of course, through WellStar, we send you to Centers for Health Health that can work on, weight loss, diet, and nutrition long term so that you can get to your long-term goals.
Wow. And so those three takeaways are, if you have diabetes, obesity, and hypertension, then we really need to be very thoughtful about planning for that pregnancy and really getting those chronic conditions under control. Obesity, I've learned, just sort of causes marked inflammation throughout the body
Mhm.
and just lends itself to about 250 different potential health problems. So, and I love what you said, like it's not about wanting people to get to a perfect weight, but it's to get to a healthier weight so that the impact of the pregnancy on the body is not as profound. In addition, obesity can lead to some dysfunctional labor patterns. Folks who have really high body mass index are at an increased risk for even like cesarean delivery
Mhm.
and difficulty getting into and maintaining a normal contraction pattern in labor. So there's so many things that sort of play into that, but it is a difficult conversation to have with patients. How do you sort of ease into that conversation?
Is it, I always think, Joy, that the direct approach is the best approach. I'm very real with my patients. I share my own personal struggles with weight. I share my own family's personal struggles with the weight because I tend to think we're we look good, okay? We are good looking people, but we're thick, right? We are thick, we're curvy, we have all the things, right? And it doesn't make you an unattractive person. It just means that, hey, this number is a risk factor. And we don't treat to the number, but we want to make sure that we're getting our body mass index at a point where you're as healthy as you possibly can be. So I usually share my personal struggles with weight. I share what I've done to lose weight. I've shared what my family members do. And so I think once people realize that you're not trying to judge them or fat shame them, then they're okay talking about their own struggles, especially when you're talking about preconception conversations. Like, I just want you, my job is to make sure you and your baby get safely through this pregnancy. That is my goal, that two people get through here safely. And you can send me a picture of your baby, put on my baby board because, yay, we got you here, right? So I make it, I lay out a game plan for people. I say, hey, listen, this is what we're gonna do. I'll do it with you because even in my office, we have people that are trying to lose weight. And Joy, I have people doing 20 squats an hour this month to the
Okay.
tone, right? Because it's all about, you know, keeping your body moving and being active and making sure that we're making the right choices of putting, of what we put in our mouths. It's not about getting to a specific number per se, but you just want to live a healthier lifestyle. And even weight loss as little as 10 pounds will not only help reduce your risk of these metabolic conditions, but it help you ovulate. Obesity in itself can throw off your cycles, can have you not ovulating, and can cause you to, make it much harder for you to get pregnant. So that weight loss of as little as 10 pounds, and that's usually what I set the goal, like, hey, let's circle back in 3 months. Let's see if we can lose 10 pounds. And let's talk about what's realistic for you and what your barriers are. And most of the time people are like, I'm working all day, or I don't have the time. I have other children. I can't afford to go to the gym. We always have an excuse for things. Me too, right? Me too. But if we try, just put our best forth, but our effort, bet our best effort forward, then we can take those like tiny micro steps. And so I always tell people in the conversation, I'm like, I don't want to put you on a diet. I'm definitely not going to put you on a diet. I just want you to move more and don't drink your calories. Water. If people can cut off soft drinks and, fruity stuff and just drink
And
water.
double caramel macchiatos
Yeah,
and,
just don't drink your
like,
calories. Just drink
yes.
water. If you can start there, if you don't even change your diet and just drink only water for your beverages and walk for 30 minutes. Like literally just don't sit down after you eat for 15 to 20 minutes every meal. You've walked for 45 minutes. And so when I say it to people like that, they're like, "Huh, I didn't really think about just drinking water and moving around more after I ate would count." I'm like, yeah. Like literally, like wipe the countertops down after you eat your meal. Go ahead and take your shower at night. Fold your clothes, get your clothes laid out on the bed. Instead of sitting and vegging out after you do a meal, like literally be intentional about moving around for 15 minutes after each meal.
Mhm.
That in 3 months, I'm like, you will definitely lose 10 pounds doing that. If you don't drink your calories, you drink only water and you move around, even if you still eat the fried chicken, you will lose 10 pounds because you're not drinking your calories. So I usually come from a very realistic standpoint. I want to know people's barriers. I want to know what they like to do. So maybe we can do some things that you like, and then circle back and say, hey, let's meet in 3 months and see where we are with this.
Right. I think that is so amazing because you're giving people really practical advice about how they can make small changes that will have a big impact. And one thing I need to sort of add to the conversation is that we understand that social determinants of health play a big role here. Like
Huge.
people having hypertension, diabetes, obesity, and having all these cardiometabolic risk factors, a lot of that comes from the social determinants of health, from the communities that we live in. And like you said, we're good looking people. We say we always have that old adage, black don't crack. But weathering really does age us
Yeah.
metabolically, and down to the level of every cell in our body. So, we may be more susceptible to some of these chronic conditions, right?
Right.
So I think it is important to just add that caveat in there. Maybe people are living in food deserts, and that's why they're developing obesity. Maybe folks live in places where they don't feel like it's safe to walk around for 30 minutes in their neighborhood. So there are a lot of issues at play. It's not just that we're all fat and lazy and eat bad things. It's just that our culture tends to appreciate more curves, but then also there are all of these social factors at play in terms of what we have access to and what we're able to do in some instances. Not every Black woman's experience is exactly the same, but we know that there are definitely some social issues that are at play here.
And Joy,
So
there's a lot of similarities as well. When you talk about weathering, um, there's that American Heart Association study that looks at Black women and it looks at women that are immigrants and are women of color. And they don't have the same rate of hypertensive disorders or preeclampsia as Black women that are African American that have been in this country for generations. But after 10 years of being in the country, then you start to see that those rates are the same as rates of Native Black women in America, and that lends to chronic stress, weathering, which is because of, implicit bias and racism. So those things can also weigh and play a huge role in, these chronic metabolic conditions. Because if you're under stress, obviously that drives your cortisol level up, which makes it harder for you to lose body fat, which makes it even more common for you to get things like high cholesterol and diabetes. So yes, the environment that you live in definitely play a huge part of that.
Yeah, I definitely just wanted to lift that because that's something that, I see a lot sometimes when we're talking about higher risk pregnancies. People sort of tend to shame and blame and not really look at the factors surrounding this. So I think it's very, very important to lift that. You know, um, you know, you mentioned a little bit about gestational diabetes and hypertensive disorders. Like, what do you see as the long-term impact on cardiovascular health for folks who may develop hypertensive disorders of pregnancy or who have gestational diabetes going forward, like into the future? How does that impact our ability to be healthier after pregnancy?
Pregnancy weighs on you. I mean, I tell people all the time, pregnancy is not benign. Even if you're like, I got through my pregnancy uneventfully, it's not benign. I mean, pregnancy does weigh on your vasculature, even in the healthiest pregnancies. And the more pregnancies have, of course, the more insults you have, right? The more insults and impact to your vascularity you have. People that have gestational diabetes, yes, after that placenta is delivered, the diabetes tends to go away, right? Because gestational diabetes is caused by hormones secreted from the placenta. But those hormones also weigh on every organ in your body. And they do go away, obviously, over time. But we know that people that have gestational diabetes do have an increased risk of developing type 2 diabetes, with 50% developing type 2 diabetes between years 3 and 10 years post delivery. So it's really important that after you are delivered, that you continue to have your wellness with your primary care doctor, whether that is a family medicine doctor or an OB-GYN or a combination of the two, to do things like metabolic screening, screening your cholesterol, screening you for development of type 2 diabetes with an A1C and your either random glucose levels or your fasting level if you have morning appointments, so that you can get early intervention, and then they can do some risk reduction strategies so that you won't develop poorly uncontrolled diabetes. Hypertension. We know that people that have preeclampsia have an increased risk of cardiovascular disease and heart failure. We know that people that have preeclampsia have an increased risk of having heart attacks and strokes later on, with people developing those issues within 10 to 15 years, usually after delivery, and some even sooner. So it's really important that after delivery, all women, not just those that had gestational diabetes and preeclampsia or other hypertensive disorders of pregnancy, but just women in general, because pregnancy does weigh on your body. It does cause your body to change. When people say, I just don't feel like myself, well, you're not yourself. You are different now. Okay. Your body has gone through a lot of changes. Your heart, your brain, those hormones that are secreted from the placenta really do impact every organ in your body. So your body does change after pregnancy. Even your mood changes after pregnancy. Those hormones definitely have a huge impact, and those conditions, if you develop them, do have some downstream impacts that need to be closely monitored after you deliver it, especially within that 5 to 10 year mark after pregnancy.
Yeah, totally agree. And I love that you mentioned the preeclampsia development in some women. And we have to acknowledge that preeclampsia doesn't impact all women equally, right? For many of our patients, especially Black women, it's more common and it can be even more severe in us. And I think, that has a lot to do with the overall impact of weathering that we see in Black female populations. And so it's not just a clinical issue, but it's a health equity issue, right? And if we're paying attention, preeclampsia is also one of the clearest signals that we have some underlying heart disease that's going on. And that's why it's so important that we are partnering with our cardiovascular disease colleagues, with our cardiologists and others, to make sure that patients who have been diagnosed with preeclampsia are getting the appropriate follow-up. So you mentioned that 10 to 15-year window where these folks may actually develop gestational diabetes or heart disease after having had some complications of their pregnancy. So because pregnancy is that big stressor on the heart, on the kidneys, on multiple organs in the body, you can sort of get hints that this person may actually be someone who is dealing with some underlying disease processes that just haven't manifested yet, but tend to manifest during that pregnancy because the body is stressed to the max. So, how do you communicate these risks to patients in real time? Because, let me just give you a scenario that I had today in my clinic. I had a lady who was over 35. Body mass index was 54, so that's like in the 300-pound range, and had a history of a blood clot in the lungs. And she comes in and she is super excited because she is pregnant. And so I had to have a really real conversation, but it's like, how do you have these real conversations without diminishing the joy and the excitement that this person has, right? So how do you talk to people about these very, very real risk factors without busting their bubble?
Well, Joy, I don't diminish the joy. I say, oh my God, you're pregnant because guess what? They're excited. They are pregnant. And for me, I'm like, I'm going to deal with what we have on the floor, right? And it is exciting to have a baby. And if someone is excited, I want them to be excited about having a baby. I'm excited for them. But I'm very real. I'm like, my job is to make sure that you and your baby get here safely. So let me talk to you about all the risk factors. And I do. I lay out all the risk factors because it's my job to do. And usually when I do that, Joy, and I say, listen, you have an increased risk of another blood clot this pregnancy. You're going to need to be on blood thinners. This is life saving. Okay. You're going to be on these blood thinners the whole pregnancy. And then after the delivery, you need to be on the blood thinner at least 6 weeks after pregnancy. Your hematologist may want you to be on it longer, depending on the timing in which she developed the blood clot. I'll say, hey, your BMI is high. No, I do not want you to lose any weight this pregnancy. I actually want you to gain weight, but the average amount of weight you should be gaining is we're going to follow the growth of your baby pretty much every 4 weeks to make sure that the size of your baby is normal. These are things you have an increased risk for. You have an increased risk of having hypertensive disorder of pregnancy, like preeclampsia, developing, heart disease, which can lead to a stroke or heart attack. You have an increased risk of getting gestational diabetes or diabetes that's caused by hormones from the placenta. You have an increased risk of needing a C-section. But my job is to make sure that if you develop any of those things, that we are going to do everything we can to keep you safe. And I think when people get all of the risk and they know these are the things we're going to be looking for every time you come, and these are the things I need you to do at home to decrease your risk, they're more likely to be compliant because they know that if I'm not compliant, there can be some things that happen that nobody knows about. And I tell people straight up, if I don't know that you're having symptoms, if you don't come to your visits, it's going to be hard for me to intervene. It's going to be hard for me to know when to admit you. It's going to be hard for me to know when to recommend that you be delivered. And it's going to be really hard for me to recommend a different timing of delivery other than your due date. So I need you to communicate. I need you to be open with me about how you feel. And I need you to come to your appointment so that I can check on you. And most of the time, people are okay with that, right? I don't want to bust their bubble, but my job all day, Joy, is to give people risk. So those risks rattle off my tongue.
Hmm.
I have no issues giving it, but I am very real with people, and my job is to make sure that if they happen, I can't prevent all of them, but these are the things we can do to reduce your risk of preeclampsia. I want you to take this low dose aspirin. I want you to take it every day. Even if you skip your prenatal vitamin, I want you skipping this one because this is the only thing we have that can reduce your risk of preeclampsia. So I want you to take it every single day. I want you to take this Lovenox every day, okay? Twice a day. I want you to take it because it's the only thing that I have that can make sure you don't get another blood clot. Things like gestational diabetes, I can't reduce your risk. There's nothing to reduce your risk at this point. I don't want you losing weight. But these are the things I want you to do to make sure that you're doing your part in making sure you're controlled. And if you develop gestational diabetes, then we'll switch your diet up. And if your diet is changed, if you develop gestational diabetes and it's uncontrolled despite your diet, then we may have to start you on insulin. And that's when it's my job to give you the medicines that control your diabetes after you've done your part. So I have my part and you have your part in this pregnancy. And we both are a team and we're going to get through it together. And so once I've outlined that plan and I send it to them via my chart and we call the next day. I usually always call the next day, Joy. If I have to give somebody a ton of risk because they have a history of a blood clot, a history of a stroke, a history of a heart attack, they have diabetes already, that's a lot of things that I have to talk to them about. Usually I'll follow them up the next day and say, "Hey, I just want to check on you. Just want to make sure you don't have any questions about anything that I've said," because sometimes it can be overwhelming for people. Sometimes I mean, I say things and it goes in one ear and they're like feeling defeated. Well, I don't want people to feel defeated. I want people to feel
Mhm.
empowered when they leave the office. Like, okay, I have my to-do list here. She has her to-do list, and we're going to work together to make sure that I'm safe. And we'll get you through this pregnancy safely. Now, Joy, what happens is sometimes we do such a good job that people don't really understand how high risk they really are, especially the people that I have that have heart disease.
Right.
I'm like, you
That
have
part.
aortic stenosis and you've had a stroke. And they're like, but I feel like I was in good hands. I'm like, yeah, but that doesn't mean that we shouldn't be waiting a little while and making sure that your health is optimized again before you get pregnant again. They're so comfortable and so confident in our care that they're like, Dr. Plenty has me. I'm like, yeah, but you still got risk factors. You still got to make sure between these pregnancies that
Right. And
we give our
meanwhile, we're having
bodies
gray
a chance
hair and
to,
palpitations,
right,
trying to
that we give your
trying to
bodies
figure out
some
how we're
grace.
gonna get this done
Right.
safely.
We're
Yes.
having multidisciplinary meetings
Right.
about you, ma'am. I'm glad that you feel confident and we have a plan, right? Because when we have that plan, usually nothing happens, right? We've done everything and usually it's smooth sailing when we have that plan on board. But man, people don't understand how, sometimes it's just like a wish and a prayer, but we're really trying to make sure that we optimize and get you as far as we possibly can. We can't guarantee that with every
I
pregnancy.
was reading.
Your baby, get your
Yeah, and
baby,
I was reading about how actually going through the third trimester and birth requires as much energy expenditure as running a triathlon. And so one thing I've started doing when I'm talking to patients about, planning for pregnancy is sort of explaining that, like, you need to be in the best shape of your life. Like,
Mm,
get, your health optimized as very best you can so that you're going to be able to run this race safely. You're going to get to the end and you're going to be victorious and you're going to take your baby home and love on them. So, I love what Leslie is saying in the chat about when we're talking to patients about a whole lot of risk and a whole, all these things that are going to need to be done. She talked about it's very important to bring someone with you or have someone on speaker because sometimes when you're hearing that, it's a lot to take in. And all you're thinking is, man, I was really excited when I got here. And then she just told me
right,
all these things that, that I need to do. And it can sound like a lot of gloom and doom to patients. And so I'm really glad to hear. And I think I'll put that in my practice too, to start calling the next day just to see like, hey, do you remember everything we talked about? How are you feeling? Are you feeling defeated or empowered? I think that
right,
that's such a very useful tool
right.
to
Yeah.
use for
Patients
patients. So I
and
think that's
patients that I've
good.
gone over a whole bunch of stuff, I definitely will personally call them. But we have a team of people. I have a nurse midwife that does some follow-up calls. I have a nurse navigator that helps to make sure that people understand what's going on and they're able to fill their prescriptions and things like that. So yeah, I think it's important to have those touch points with patients. And speaking of having a support person, I always and I'm so proud of Wellstar and like their Wellstar doula program because if your listeners don't know, Wellstar has the free doula program. Patients have to scan the QR code, they can register and they can sign up.
Mhm.
And then obviously you can get your own doula. My high risk patients and a lot of OB-GYNs don't feel the same, but because they don't have all high risk patients. I feel like more and more patients are becoming high risk though, Joy. So I think everybody should be like practicing maternal fetal
Yes.
medicine. But especially those
Hmm.
people that are super high risk, I'm like, you need a doula. Like, I feel like someone that I'm going to have to spend a lot of time with, they are going to need a doula or at least some type of support person. But if you don't have a strong support system or someone that can come to all your appointments with you, then yeah, I encourage them like, hey, this is a little pamphlet. Like, you can scan this QR code, you can register, you can get a doula, or you can find your own doula. But I always tell people, bring a notebook with you. Like, you should never come to your appointments empty-handed. Bring a notebook with you. And if I see people don't have a notebook and it's their first appointment, I'm like, do you need a pad? Like, do you need a pad? Because I want to make sure that they're writing down the information. They know what diagnoses they have.
Hmm.
And they're also taking this home and they're writing their questions down so that they can send us messages via my chart or call us the next day or come in the next appointment with your questions. Because that's how we know you get it, right? You come in, you were questions, you can recap what's going on. And I tell people, even after pregnancy, when you go to your primary care doctor or to your endocrinologist or whoever, bring that same, like, have a health notebook, have a health journal, and write it down. To me, it's just it's so disheartening when people don't know what their medical history is. Like, that's the number one thing people can do to really advocate for themselves is knowing themselves and knowing their body. Like, you should know, like, I have hypertension. I used to be treated with these medicines, but this one didn't work. And they switched me to this because this medicine did not work. Or I had a heart attack in this year. This is the year I had a heart attack. This is the cardiologist I was seeing before I moved states. And now I'm seeing this new cardiologist. So you should know what your history is. I have lupus. I was told I was taking this medicine, but is this safe in pregnancy? Like, know what your history is and write it down. Like, that is the number one thing I tell people when I'm doing preconception consults, especially because that's when a lot of people don't know, like, I don't remember what the name of that disease, or I'm taking this little pill and it's pink, but I don't remember what it's for. Like, figure out what your medicines are for. And if you have a doctor that's changed your medicine that you don't see that often, you can always send them a message or call and clarify, like, hey, I just want to clarify, why exactly am I taking this medicine? And I would encourage, providers to like empower your patients to know what their history is, like know why they did something. And people that have preeclampsia, like, hey, you have preeclampsia. Make sure you tell your next doctor, if it's not the same doctor, that you have preeclampsia. Or, hey, I did a classical C-section on you. You are going to need repeat C-sections no matter what, because this is a classical C-section. Your risk of uterine rupture is much higher. That's when that previous incision comes open. So that people can know what's going on, so people won't have to guess, or I'm waiting a week to get records, and you're like, oh, this person has rheumatoid arthritis and they didn't know it. Now their baby can have heart block, and I need to get them into MFM like immediately because it should have been, getting PR intervals. Those things can help us along the way in planning out the pregnancy, just knowing your history in general.
Right. And that's such a huge part of healthcare at any point, whether you're pregnant, not pregnant, just knowing like what has happened to you in your body, what medications are you placing in your body, what things is your body sensitive to, your allergies and all of these sorts of things. These are all very important things for anyone, regardless of whether or not they're pregnant. Sometimes they become even more important during the pregnancy. Like you said, some of these conditions may actually affect the fetal health as well. So we really need to be looking for to make sure that the baby is developing normally and that the mom is doing well, and we're kind of watching them a little bit more closely. But I think, even all of the things that we're talking about now apply to all patients. We are coming up on Black Maternal Health Week here in the States, but I noticed in the chat people were like, "Well, is this only about Black women?" But we're sort of centering Black women because that's what we do with Safer Births Now and with Birthing the Magic. But this, you know, when you improve maternal morbidity and mortality across the board, it's going to help everybody, right? And in the United States, unfortunately, we know that Black women are 3 to 4 times more likely to die than their white counterparts during or around the time of childbirth. So these are very important conversations that we're having in the United States right now about, how do we mitigate some of this? How do we understand what needs to happen to promote health equity in our country? So I think these conversations are very relevant and I think they're very important, but all of the medical stuff applies to all women, right? If
Yep.
we're talking about cardiometabolic risk factors, we're applying that to all women, but we are saying that we notice that cardiovascular disease is not the number one killer of moms who are not Black. Very
No.
interesting. So I think we need to, that's a cardiometabolic risk factors are actually very, you know, they apply to all women, but we see that Black women tend to be more affected in the
Yes.
United States, at least. And then we know that the number one cause of maternal mortality in the United States is actually mental health and substance use. And
Yes.
so our white counterparts will often have mental health and substance use disorders that lead to their demise, whereas Black women are suffering from cardiovascular disease. So I just wanted to clarify that for the audience so that, we kind of put this conversation in perspective. So you talked about saying to patients, you have preeclampsia. When you have patients that have preeclampsia, that have that risk for heart disease later, what sort of management are you doing for those patients? Like, how do you encourage them to see cardiology and, continue to follow up? How do you counsel those folks who had preeclampsia, particularly severe, preeclampsia with severe features? How do you
Sure.
counsel them?
So first I tell them, hey, you have preeclampsia, and usually I'm diagnosing this in the inpatient setting, right? So a patient that has been sent to the hospital for evaluation because they have high blood pressure, and then we're looking at their liver function, their kidney function, their 24-hour urine protein or their protein to creatinine ratio to diagnose that, right? So diagnosing preeclampsia is just high blood pressure, two elevations 4 hours apart are documented on two separate occasions, in addition to proteinuria. That's all you need to diagnose preeclampsia. The other things are just little tidbits extra, right? So if you have an increased serum creatinine, which is what tells us your kidney function, then that means you also have acute kidney injury on top of preeclampsia or caused by preeclampsia. Some people can have transaminitis with elevated liver enzymes as well, which tells us that you may not be a good candidate to conservatively manage. And when I say conservatively manage, I mean keep you pregnant for at least 34 weeks or 37 weeks, depending on if you have preeclampsia with severe features or without severe features. So if you have underlying kidney disease or, your LFTs or your liver function tests are abnormal, or you're having a headache that won't go away, or any symptoms of, double vision, blurry vision, pain over your liver, then or you have unresponsive blood pressure. So we're pushing IV antihypertensives and nothing's happening. You are not a candidate for conservative management if you have preeclampsia, and it doesn't matter what the gestational age is, that may mean you need to be delivered. So I usually tell patients, hey, preeclampsia can put you at increased risk for some bad stuff happening. Our job is to make sure that we intervene in just the nick of time so that that bad stuff won't happen, right? So our goal is to keep you pregnant for fetal benefit at this point, not for maternal benefit. And the further we get you out for the baby, the better, but we don't want to risk your health for the baby's health. Okay, so if you remain asymptomatic, if your labs remain completely normal, then that means it's safe to be pregnant. If any of that changes, that may mean you need to be delivered. The things that we look for in pregnancy with preeclampsia, development of kidney disease, development of worsening or liver disease, symptoms that could sort of give us a clue like, is this person stable or will they end up developing an eclamptic seizure, which is seizures caused by hormones from the placenta? That can put you at risk if you have uncontrolled high blood pressure for a stroke or even a heart attack. So those are the things that we monitor people for. And of course, if people have severe features, meaning they have high blood pressure that we're treating with antihypertensives, plus proteinuria, but their kidney and liver functions are still stable, then those are people that we can try to conservatively manage even with severe features. Then I tell them, hey, if you become unresponsive to antihypertensives, meaning you keep on throwing high, severe range blood pressures, 160 over 110 blood pressure, either systolic or diastolic number in the severe range, then that would mean that you need to be delivered. And then I counsel them about, most people want to know, well, what's going to happen to my baby, right? Like, what do you mean I may need to be delivered early? And that conversation, Dr. Baker, really depends on the gestational age in which the patient is, right? So if a patient, it's a much
Mm.
different conversation if a patient is 31 weeks versus a patient that's 24 weeks, right? So your 24-week person, we're having to have really tough conversations and saying, hey, if you need to be delivered at 24 weeks, for every week a baby's born early, that's a week a baby could be in the NICU. The steroids that we will give you for fetal lung maturity, which we give 2 doses of betamethasone 24 hours apart, help cut that NICU time in half because it helps with the development of the lungs. Um, but that's still time in the NICU that your baby will spend. And when we talk about survivability, 24 weekers still have a high chance of not surviving. They have up to 40% chance of not surviving. And when we talk about survivability, we'd be remiss if we did not talk about the difference between neurologically intact survival versus non-neurologically intact
Mhm.
survival. And that means that
Yeah.
your child
Yes.
would go to school and walk and talk, and meet milestones like any other child its own age is very low at 24 weeks. We're talking 10% neurological survivability at 24 weeks, 10 to 15%. So we do have to have those conversations versus somebody that's 31, 32 weeks. Obviously your neurologically intact survivability is way higher. We're talking 80, 85%. So it's different. It's a different conversations, but we have to let them know that our goal is to make sure that we optimize your health and make sure we keep you safe, while we're trying to push your baby out as far as we possibly can. And then after delivery, that weighs on your heart, right? We want to make sure that you're seeing the cardiologist within 2 weeks of delivery. If you're inpatient, we usually consulting the cardiologist. If you're someone that is outpatient and maybe you don't have severe preeclampsia, maybe you have gestational hypertension, maybe you have preeclampsia without severe features, so your blood pressures are only in the mild range. Usually we'll send a consult to our perinatal cardiologist so that they can see that patient periodically just to establish care so that it's not going to be difficult to get them in after delivery. And usually we're seeing patients, if they're outpatient with gestational hypertension or preeclampsia without severe features, they're treated basically the same. They're going to be seen twice a week. We're going to monitor your symptoms twice a week. We're going to check your baby twice a week. We're going to draw labs on you at one of those visits. So every week you get labs for preeclampsia as well. So we follow those people very, very closely if they develop that, and then they need to be delivered at 37 weeks if they have gestational hypertension or preeclampsia without severe features. Obviously, preeclampsia with severe features, they will be in the hospital and delivered at 34 weeks or the time of diagnosis if it's after that time.
Yeah, absolutely. Just last week, I had a patient that had preeclampsia with severe features. So I admitted her until 34 weeks, and she actually did okay. And then, right at the time of the induction, had a massive, the placenta came off the sidewall. She started throwing these really high pressures, and she had bleeding into the actual uterine muscle, had to have an emergency C-section. Thankfully, she and the baby went home just fine. But that's one of the reasons why you might have, a physician or a midwife or someone who wants to put you in the hospital and keep you in the hospital. Because I can't even imagine what would have happened to her and the baby had she been home and trying to come in for, trying to come in emergently. So, and I practice in a more rural area. So I have instances where the ambulance can't find people's homes because they live
Oh,
like in the
wow.
middle of the boondocks. So, I will hospitalize people all the time just because they live really far away. They live on a farm somewhere where GPS, you'll be lost forever trying to get to them urgently. So, will keep those patients with me so I can keep an eye on them. And I was so thankful. And she was like so thankful. Like, I really did not want to be here for a full week sitting in this hospital, but thank God I was because I ended up really needing to be here.
Yeah, and
So,
you can't predict
so
when you
those
need
are
to be
some
there either.
things. Right. And I would never have been able to predict. She looked fine all week, and people were like, "Oh, do you think you'll send her home?" And I'm like, "Nope. I'm going to keep her until 34 weeks, and then we will deliver." So I think it's really important that we're being very, very mindful and paying close attention to what's happening with our patients. I think that that's part of the reason that we're sort of in this situation that we are with maternal morbidity and mortality, is that we haven't been as strict as we should have been on following the evidence when it comes to patients. So we are about to wrap up. We have just a few minutes left. What is your one key takeaway for both clinicians and patients when it comes to cardiovascular risk factors?
So my key takeaway from for patients is to optimize your health before you get pregnant. If I cannot change one thing, if I could change one thing about every patient that I've seen that has a high risk condition, I wish they would have all had a preconception consultation and they would have a plan for themselves before they got pregnant to optimize their health. So I would say that is the takeaway message I would give to them. And I'll give you a second one. Make sure you know your health. Okay. So if you're optimizing it, make sure you know your health, especially if you're someone that has, very complicated or complex comorbidities. Bring a notebook with you, write things down, write your questions down. For clinicians, I would say trust the numbers. There's so often that people get their blood pressure taken, and I'll see it. Like I'll have patients that come in, and I'll say, "Well, your blood pressure was elevated on Monday. What happened on Monday?" "Oh, well, I was rushing, and they said that was because I was rushing or I was nervous." You have to believe the numbers, okay? And even if a patient is rushing, even if you think a patient does have white coat hypertension, it's not going to hurt for you to draw the labs and make sure they don't have preeclampsia. So always, if you have people that have high blood pressures, trust the number. Don't excuse away the numbers. Always do the testing, always follow up. You will never regret getting those labs drawn or sending that patient to the hospital to be evaluated. And then you can always send them home. But if you didn't and you're like, "Oh my goodness, this person came back in and now they're seizing," I guess it wasn't white coat hypertension. Like you have no medical legal leg to stand on if you don't follow up and evaluate those numbers.
I tell you what, thank you so much for saying that, Dr. Plenty, because that is my number one pet peeve. Number one, I don't want to, I get these blood pressures and folks are like, "Oh, well, she was arguing with her boyfriend on the phone and that's why her blood pressure is high," or this or that or the other. And so all of the nurses I work with will tell you that they hear me say one thing almost every day: believe the blood pressure, right? Let's work it up. Let's treat it, because we know what, if you overshoot, we know how to take care of that, right? On labor and delivery, if you drop the blood pressure, we do that all the time with epidural. So we know how to bring it back up. But don't let people sit around with severe range high blood pressures for any reason at all. I don't care if they're, there's just no excuse for someone's, I don't care how stressed they are, their blood pressure should not be in the 170s over 100s, right?
Mhm.
That's just, that's not normal. And matter of fact, a pregnant person with high blood pressure should send off alarm bells in your head, because the physiologic changes of pregnancy actually lower the blood pressure. So we
Correct.
should not see people just randomly walking around with high blood pressures who are pregnant. We should see lower pressures in pregnancy.
Right.
So I think that's a great takeaway for us as clinicians, just to remind us, like, pay attention to those blood pressures, work them up, and treat them. So what gives you hope for the future of maternal cardiometabolic health?
Hope for the future. I'm a pretty positive person. I tend to be very positive. But Joy, I I don't know. I mean, I don't know what hope for the future, because this is the thing about the future. The future is very confusing right now because a lot of my patients from 2025 to 2026, and I won't go on a soapbox because I can, have lost insurance, or their premiums have gone up, or their
Hmm.
copays have gone up.
Yes.
So it's making it harder for people to get into their OB-GYN, and definitely harder to see someone like me. So that to me, it upsets me. It upsets me. My hope for the future is that there is some type of expansion of cover. That's my hope for the future, is that we have some expansion of coverage so that people can have more access to OB-GYNs and more access to maternal fetal medicine. Whereas right now there's 82 counties in Georgia that have no OB-GYN. I'm not talking about like APPs, but no OB-GYN. That is absurd to me. So my hope is that we produce more doctors, that we get more people in these rural areas, that we are able to, have expansion of coverage for patients so they can get the prenatal care and the access
Mhm.
they need. Because I'm telling you, we are spacing people out as much as we can and doing as much as we can virtually just because of barriers to healthcare and access issues. So that is my hope for the future. I will say that.
Right. And hopefully, too, we can start to do, my hope is more preconception health. I think we really, really need that. But without expansion of coverage, it's really hard for people to get that because they may not have access to healthcare coverage until they are already pregnant.
They're pregnant.
So, that makes it really difficult to do preconception health. And so we have a couple minutes left. I just wanted to see if there were some questions from the audience. There was one question that I saw a little bit earlier about what do you think about weight loss in the first trimester for people who have obesity or are overweight?
I don't like it. I don't want to encourage anybody to lose weight in pregnancy. I think it's the only time that people can do what they want to do and not worry about losing weight. I don't want people to lose weight in pregnancy. I want them to, and most people, if you have nausea and vomiting, you are actually losing weight in pregnancy, and you sort of catch up in the second trimester, with the majority of people gaining the most weight in the third, right? But I don't encourage weight loss in my morbidly obese patients. I encourage just weight maintenance because I want them to be active, but I don't want them to take on a whole, workout regimen that's going to cause them to, lose weight. Because if you're working out before the pregnancy, then you can continue to work out throughout the pregnancy. But pregnancy is not the time where you should be starting some brand new weight loss or exercise regimen, because that can have a detrimental impact on the pregnancy as well. So I don't encourage weight loss. I just encourage weight maintenance and for patients to be more active.
Agreed. Agreed. Weight maintenance, stop drinking those calories and move. I think those are some very practical tips that we can take away. Well, I just want to say thank you so much for joining us today, Dr. Plenty. This has been a very informative, insightful conversation. Thank you as well to the audience and to our sponsors, Safer Births Now and Birthing the Magic. We hope that you will join in many of the conversations that are happening this week and next week. So we'll have plenty more expert content coming your way. So thank you so much again, Dr. Plenty. We really appreciate your time and expertise.
Of course. Thank you so much for
Bye,
having me.
everybody.
Bye bye.